We will now learn more about these clinical tests from Dr. Brian Hill's presentation. Dr. Hill is the Director of Lymphoid Malignancy Programs and a staff physician at the Cleveland Clinic Tausig's Cancer Institute. His primary clinical and research focus is in CLL and lymphoma. He's the principal investigator on multiple ongoing clinical trials of new cancer therapies, including novel cellular therapies, and has published extensively on related to this topic. Dr. Brian Hill will be covering prognostic and predictive testing, disease monitoring, and the role of MRD, measurable or minimal residual disease testing. Welcome, Dr. Hill.
Hi there. I'm Dr. Brian Hill from the Cleveland Clinic Tausig's Cancer Institute. I'm speaking today for the CLL Society on treatment decisions, predictive tests, disease monitoring, and the role of minimal residual disease for chronic lymphocytic leukemia. It's October 2021. And today the learning objectives are to discuss prognostic and predictive tests. These are mostly molecular tests. When do we need to repeat testing? We're going to talk about bone marrow biopsy and or the need for imaging for treatment, and disease monitoring, including simple labs like the complete blood count, some tumor markers, role of imaging, and what is the role of bone marrow biopsy. At the end, or the second half, we'll talk a lot about minimal residual disease testing. So by way of overview, we're going to be talking about the difference between predictive and prognostic testing. It's really important to have appropriate molecular testing before treatment for CLL, as these tests may determine which therapies will work and which will not. By way of definition, a prognostic marker is a test that may help predict the likelihood of a outcome for a group of patients with a particular disease or cancer. And a predictive marker is something that will help to predict the likelihood of benefiting from a particular treatment. Obviously, CLL is a very heterogeneous disease, meaning there are many different manifestations and types and ranges or paces of which it can behave. And some of these markers help to give insight into that. So you can think of your particular brand of CLL as being the unique features of it that will determine possibly the ability of it to resist certain therapies and how sensitive it may be to others. And this is really important in tailoring appropriate therapy. Some prognostic and predictive factors can change over time. This is important to know. And it's important to at least consider being retested in many cases before starting the next line of therapy. Even if you're tested at diagnosis, some of these things can change. So what do we test for before treatment? Let's talk about some of the prognostic markers. Well, this is a long list of sort of funny sounding or different sounding terms and phrases, and we'll talk about each one of these individually. You'll hear about the FISH test. This isn't the fish in the sea. This is a fluorescence in situ hybridization assay, which is a test on usually on the blood or bone marrow sample that can give information about the particular chromosome changes inside the CLL cell. A karyotype, and we'll see examples of that, is an older way of showing similar information and sometimes more information than a FISH test. We'll talk about IGHV or IGVH. It can be is frequently referred to both ways, and a couple other words on here that we'll get to in more detail. It's also some new technologies that allow for both prognostic information, for instance, IGHV, and MRD monitoring. Let's start with FISH. So these blue circle here represents a cell, a normal cell, or in this case, a CLL cell, which can be obtained from the blood or bone marrow biopsy. And if you do particular high fluorescent probes for specific chromosomes, you'll see that there are 2 green dots, 2 red dots, and 2 sort of turquoise dots. And these dots actually represent the physical location of the probes for specific chromosomes. We have a copy of each of our chromosomes from our mother and our father. So each one of these comes from one of our parents. In cancer, we lose certain genes frequently, and this often is the result of the loss or sometimes gain of particular chromosome portions. So in this case, you can see there's 3 dots and 2 red and 2 turquoise. So in this example, instead of having disomy, which means 2 copies, there's actually a 3rd copy of chromosome 12, which would be called trisomy 12. This has an intermediate prognosis in patients with CLL. And in this case, you have what's actually a pretty common signal, which would be loss of a chromosome, part of chromosome 13. And the part of chromosome 13 is delineated by the letter Q, which is the long arm, and P is the petite or short arm. So the long arm of chromosome 13 is lost in deletion 13. And actually, this type of CLL tends to have a more favorable prognosis. In the old days, and this actually goes back even back to the 1950s and 60s, and is still done today, there are old stains in which you can use a microscope to stain the chromosomes and actually see chromosomes under the microscope. And this again is you hear about 23andMe. This is the 23 chromosomes. There's 22 non-sex chromosomes, and then an X or a Y you can see on the lower right determines whether you're a male or female. And in this case, you can see some arrows here which show that this karyotype, as it's called, is missing parts of one of chromosome 11, Q, which is the long arm, and part of chromosome 13, Q, which is the long arm again of chromosome 13. So in this case, there's 2 deletions, and sometimes that happens. Sequencing, DNA sequencing, is a more powerful way to look at, on the ground level, at all of the genetic changes in the DNA of a sample of cells. And in this case, we're looking at chromosome 17. And if you look on the short arm, the P arm, the petite arm at the top, there's a gene called TP53. TP53 is a very well-known tumor suppressor gene, which acts to, just like the name suggests, suppress the growth of tumor cells. And it's normal to have 1 copy of this gene on the short arm of chromosome 17 of both your maternal and your paternal chromosomes. Sometimes it can be deleted, as in this example, you have deletion of chromosome 17p, and that clearly gets rid of the tumor suppressor gene, which allows the tumor to grow. You can also delete or knock out or cause dysfunction of the other copy of TP53 by a mutation. And this is actually the most common scenario, where you have a deletion of 17p on one chromosome and a mutation that specifically alters the DNA sequence in the gene that encodes for TP53. So now you have no more tumor suppressor gene protein being expressed, and this leads to tumor cell growth. And then there's other iterations of this where you have 1 mutation on just 1 allele, or the blue and yellow mutations on each copy of each chromosome. So just to finish out this part, I would just say that TP53 or 17p deletion typically confers very poor response to traditional chemotherapy drugs. And for that reason, it's important to know particularly if you're embarking on traditional chemotherapy treatment, what the status of the 17p test is by FISH or karyotype, but also checking the TP53 sequence by a next generation sequencing test. IGHV, also sometimes referred to as IGVH, is a little complicated. Immunoglobulins are antibodies, and they have different chains and components. They have a heavy chain and a light chain. These are like the little molecular sort of keys that go around, float. They're made by B cells, and they float around in the body and look for germs and infections and can neutralize those infectious microbial components. The variable segment of the heavy chain can go through a process of sort of shape-shifting as the normal B cells mature. And this is actually a normal process. It is called mutation for the immunoglobulin genes to change and shuffle as B cells develop different of these antibodies that can go off and recognize different shapes of different targets. IGVH is therefore a defining feature of B cells, and as B cells sometimes change into CLL, they can have an unmutated or a mutated IGVH locus or segment, and the status of IGVH actually is more favorable if it's gone through that mutational process, and less favorable if it's unmutated. So it's a little counterintuitive to tell someone that their IGVH status is favorable and that it's actually mutated, but it really just refers to whether or not the B cell that gave rise to the CLL has gone through this maturation. Patients who have mutated IGVH tend to have better outcomes with traditional chemotherapy treatments. Those might include FCR, which many of you may have heard about, or also applies to treatments such as bendamustine rituximab. With newer targeted therapies such as ibrutinib and acalabrutinib, which are BTK inhibitors, and venetoclax, which is a different class of drug, IGVH mutation status has less predictive value. So this test is really most important if you're being considered for traditional chemotherapy, which still is used, but is much less common than it was 5 or 10 years ago. You can also do newer, more sophisticated assessments of the IGHV status, which also will give a specific barcode, as you can see, just like when you go to a store and you get the UPC symbol or a barcode from a product that you're purchasing at a store. There are specific barcodes or sequences that define CLL, and this sequence can then be used to track in the blood or bone marrow the presence of minimal residual disease for monitoring after treatment. A couple other less expensive tests, more traditional tests, are things called the lactate dehydrogenase and the beta-2 microglobulin. I put a little picture of a cartoon of what the lactate dehydrogenase protein looks like. You can't really see proteins with the naked eye or even a microscope, but we know that proteins and enzymes have particular shapes based on sophisticated crystal structures, as is shown here. These are proteins that are present in all cells, but are particularly high in B cells, including CLL cancer cells. So in general, when these proteins or enzymes spill into the blood, it generally reflects more of the CLL. And so these are relatively inexpensive and simple tests that can be used to monitor disease burden and sometimes disease activity. So in summary, the bottom line is test before you treat. And test before you treat means really, if you're going to be treated for CLL, you really should have a FISH panel Typically, it's very common also to do TP53 mutation assessment and really advise against traditional chemotherapy unless there's an extenuating circumstance if you have on the FISH panel 17p deletion and or a TP53 mutation. Similarly, the IGVH status is something that should be done, and if it shows an unmutated IGHV, this is a situation which it's really not common to use traditional chemotherapy by itself or with antibodies such as Rituxan. So this is a study from a sort of a survey that was sent out to through a program called Inform CLL, which collected data on over 800 patients treated for CLL over a 3-year period. And what was found in the community setting, only about a third of patients had FISH testing, and very few, only about 10%, had IGVH or TP53 mutation assessment. And then in the relapse setting, the numbers were even lower, with only about a quarter of patients having FISH and about, again, 9 or 10% having TP53 or IGHV assessments. So those are the molecular features that need to be assessed. What about other factors? Well, of course, you know, the physical exam, general health, size of the lymph node, size of the spleen, these are all important. Routine labs are done. Blood counts, chemistry panels, including liver and kidney function, are all important. And certainly it's important to take into account other medical problems that could potentially impact your response to treatment or the risk associated with it. We call these comorbidities. And these could be heart disease, such as arrhythmias, renal, which means kidney function, respiratory or lungs, and psychological functioning is important. Going through any kind of cancer treatment is difficult, and it's important to be in the right sort of frame of mind. It's common to have anxiety about CLL during the watch and wait period, and even when embarking on treatment. So all these things need to be taken into account in a sort of holistic approach. We don't always do CAT scans before treatment. It's not wrong to, but it's usually not necessary, and it does expose the patient to a fair amount of radiation. PET scans are used in certain circumstances, but really don't need to be done as standard approach prior to most CLL therapy. And a bone marrow biopsy, I would say, is sometimes useful, often in certain scenarios is essential, but is not really mandatory in all cases prior to treating CLL. In terms of disease monitoring and assessing disease burden, we want to obviously assess treatment efficacy. That means how well it's working, monitor for remission, and then afterwards detect relapse. Serial assessments over time are required to monitor changes in the disease burden. So how do we monitor this? Obviously, physical exam is quick and easy. You can often, patients, you'll know if your lymph nodes are shrinking. If you have pain or discomfort from those lymph nodes, you'll probably be aware of that. Blood counts, including complete blood count, metabolic panel, that's CMP, beta-2 microglobulin, and LDH we talked about. Imaging, again, sometimes is useful, but not always essential. Sometimes people want to know, are they in remission? Complete remission or complete response to treatment basically means that there's no more measurable lymph nodes by physical exam or by scan. And the spleen and liver, if they were enlarged, are no longer enlarged, and the blood counts are normal. Sometimes for clinical trial purposes, a bone marrow biopsy also is required to show complete remission. So here's some of the ways that we assess disease burden. You can see at the top here, bone marrow biopsy. The FISH test is more, again, prognostic. CBC is on the lower right there. Imaging is sometimes used. And flow cytometry is a really sensitive test that can detect very small populations of cells in a fluid sample. So let's move on to MRD. In the case of minimal residual disease, we know that the lower amount of residual cancer cells after treatment for CLL, the lower the better, because this will typically result in longer durations of response to treatment. Flow cytometry can be used to detect a single cell hiding among up to 10,000 cells in a blood or bone marrow specimen. Sequencing, next generation sequencing, DNA sequencing, can find 1 in a million cells. Undetectable MRD, so UR-MRD, does not mean that there's no cancer. It may be there, but it's really just below our best level of detection. And it's actually possible to have no residual disease detectable and really to be in a complete remission, even if the lymph nodes are still somewhat enlarged, because sometimes they have scarring in them and they don't return to normal size, but the lymph nodes essentially have no appreciable cancer in them. So here's an example of minimal residual disease as indicated by the sort of peach-colored cell, which is the cancerous B cell, surrounded by the healthy blue cells. And as you can see, as you move from left to right on this slide, the remission occurs when there's really no detectable cancerous cells. And then there often, with enough time, is a period of time when the cancer cells recur. And then clinical relapse is only when you really can measure in the blood with standard approaches or on scans or physical exam the recurrence. So there are several MRD assessment technologies that are used regularly, both in clinical trials and in standard practice. The most common technique is flow cytometry, which we'll see on the next slide. But there's also the next generation sequencing, which is a newer approach. In the case of flow cytometry, a blood sample is passed through an instrument which is loaded with fluorescently labeled antibodies which recognize the cancer cells. And then a laser is actually shined, as you can see on the red line there, through the specimen, and then this excites the fluorescently labeled antibodies. Here's a representation of what those different antibodies may look like. And they have different colors, and they can be detected on sort of chromatograms that you can see on the right, example of which on the right. And depending on the markers and the antibodies that are used, you can determine whether something's a T cell or a B cell. In the case of next generation sequencing, without getting into too much details, we talked a little bit before about the variable chain. There is also other domains, a junction domain and so forth, as indicated on the top here. And this is, again, the gene that encodes the immunoglobulin protein. And this goes through a shuffling and a mutation process as normal B cells reshuffle. And depending on how things come out, you have a different, again, barcode or signature, as you can see sort of at the bottom. And this is unique to the cell and is unique to the CLL that can derive from that process. So selection of an MRD assay for use in clinical practice really should take into account several important criteria. You want to have specificity to avoid false MRD calls. So you want to make sure that it's not giving you a false positive. It has to be relatively standardized, and there are labs through the country who do this in a standard fashion. Of course, you also want to be sensitive. So you don't want to have, you want to achieve good detection. And then ideally, you have impact, patient impact, so that you can use this information to help the patient who's having the testing done. As one example, this is a large analysis of patients who underwent treatment for CLL, And as you can see on the curve here, what we call progression-free survival, which means alive without cancer recurring, is higher, as you can see on the purple line, with patients who have undetectable or UMRD, as opposed to those who have detectable MRD on the bottom in the other color. MRD assessment is now recommended in consensus guidelines from the National Comprehensive Cancer Center Network, or NCCN, as well as the IWCLL guidelines. So in conclusion, in terms of the prognostic and predictive testing, it's really important to test before you treat. It's best to retest before subsequent treatment, although IGHV or IGVH typically does not evolve, but other factors can, including 17p deletion and others. And really the predictive tests are the things that should guide therapy. In terms of disease monitoring, ongoing disease burden assessment is really critical. Role of MRD monitoring is changing and expanding as the years go by. And in terms of MRD, the MRD testing really can provide additional insight beyond a traditional response assessment that might be obtained by scans or simple blood counts. There are several testing methodologies available to assess MRD, and really these should be selected based on individual needs and practical considerations. Patients who achieve undetectable MRD really have improved long-term outcomes in general, we know that. And in the context of patient care, there are ways that MRD may be useful to inform CLL management. For instance, if you're having a toxicity or side effect from a particular treatment and you're on a therapy that may lead to a high rate of undetectable MRD status, then that may be a scenario in which it would be useful to check MRD. And I think we'll see this evolve more in the years to come. So with that, I will thank you for your attention and hopefully have time for questions.